Ben, thank you for sitting down and joining me. We appreciate the time here. We're here at Nashville, the AAPCP conference. For folks out there, can you just provide them a brief background on who you are and where you work and what type of work you focus on?
Yeah, happy to. So my name's Ben Ulrich, work at VMG Health. I've been in physician compensation valuation now for 15 years, which has been a turbulent and evolving 15 years for the industry, right? We've seen this market explode over that time frame, which is really exciting. I'm based out of Dallas, and work at a valuation firm that just specializes solely in healthcare valuation and consulting. So my little niche in that group is all things physician comp, from employment with providers to PSAs and tangential contract arrangements with physicians who are in a position to refer. And my role is mainly one to help health systems from a compliance perspective document that terms are fair market value and reasonable.
That's excellent. You really focus on the fair market value and the commercial reasonableness. In the last 12 months, have you seen a specialty that's maybe bubbled up or given you some more heartburn for your clients?
I feel like over the last 12 to 18 months, if it's not the number one specialty that we're seeing, it's at least top three: radiology. So many clients have been struggling with oftentimes their radiology group for many years approaching them for the first time for financial support. Radiology groups have been under quite a bit of financial duress, both with top line reimbursement squeezes and operating cost pressures and difficulties sourcing providers and these surging nighthawk costs and prices that are oftentimes quite large and can be exorbitant. That financial squeeze has caused them to approach those health systems for financial support. So from our perspective, when we see that, we dig with clients on, okay, well, realistically, are they collecting what they should based on the payer mix and the patient population and the types of scans that they're reading? And then, what does their operating makeup look like, right? What's their balance between remote readers and, on-site staff, if there's any interventional radiology work, they leveraging any of those third-party vendors. So it's financial analysis mainly, but the biggest thing for us is educating the client, because like I said, for many of these health systems, they haven't had to subsidize radiology in the past, or maybe they've only done it to a small degree. And so, this kind of massive impact on the industry, right? Pushing these groups to make that ask, right? Oftentimes the price tag is steep, right? We've seen some clients who've never subsidized it in the past going from zero to a $20 million, financial support package is huge. It's a huge leap, right? So it's fair market value, and it's within our realm of trying to help our clients document that, but it broaches beyond that to the operational reality of like what these health systems are having to deal with, and the budget constraints, and the future landscape, and helping them sketch that out. So I find that to be we can do the numbers all day long, and that's great and that works, but I find that to be a much more rewarding part of the job, the consulting and education side of it.
It's interesting you talk about radiology. You have this hospital-based service line. The structure of the arrangements have been evolving and changing to a subsidy, a PSA arrangement. Are there maybe terms that people are more asking for? Maybe is it like a recruitment incentive? Are there types of terms that maybe they're structuring the types of services to keep the budget within line? How has that evolved?
Yeah, it's a good question. They come in all shapes and sizes. We do see, we've seen radiology groups approach and say, hey, just help me with subsidizing my third-party televendor for the night work. We've seen We've seen a lot of subsidy stipends for interventional radiology, like I mentioned, mostly because that's typically going to require some on-site support and call coverage, right? So that the economics of that service line are just a little bit different than traditional diagnostic work. But everything from collection guarantees to APP support to recruitment support, right? It comes in all shapes and sizes, but it stems from the economic pressure that those groups are being faced with and squeezed by. It's really driving the ask.
Also, too, it's really interesting to see the evolution of the Medicare fee schedule, too. You have challenges, I think, from an operating standpoint, that you're paying physicians on one fee schedule, you're collecting on another one, and your market data is based on who knows what fee schedule. Right. When you're tackling that type of approach, what are some of the things that you look for on trying to carve out what is the best data? How do we normalize that? How do we incorporate that into the financial terms?
Yeah, no, that's an important topic. One that, we were really, the industry forced right to our face in 2021 with the big physician fee schedule change that we saw, the massive shift in office-based work RV weights. But with radiology specifically and fee schedule calculations and application, I mean, there's the one side of the ledger where you're trying to make sure you're understanding, okay, realistically, or what do the collections look like? What should they be collecting based on today's environment, today's reimbursement rates, and their payer contracts? But separately, when we're looking at physician comp and thinking about benchmarking and work RVs, right? Making sure, to your point, we're attempting to normalize the data to what we see to be the most likely peer group in that market data, which that has evolved here over the last few years as that data has drifted further and further from the 2021 impact. But, from our perspective, we attempt to align as best we can the baseline work RV weights with what we see from a market survey standpoint.
Yeah, interesting. I also think you touched on it earlier about providing education to clients. Yeah. Have you seen how the space has evolved? I think more and more health systems are hiring provider compensation professionals. How has that changed when you work with clients, or the sophistication of clients that you work with now? How has that changed in the last 5 years?
It's evolved quite a bit. I mean, today you still, there's not one client there's no one size fits all for a health system, right? Everyone is coming from a different perspective, a different risk tolerance, a different infrastructure makeup. So coming in the door cold and fresh, like the first thing we do is attempt to say, okay, what's the environment here? Like, do you have a compliance team, right? have you invested in a physician comp team? Some clients have incredibly robust teams, which is really impressive in, thinking back 15 years ago when such things didn't exist, right? So, but kind of understanding the spectrum of how sophisticated are they, right? Are they attending a conference like this? Are they, are they knowledgeable in, in how to interpret market data, right? Are they knowledgeable in how to, assess and structure physician compensation, right? That helps us tailor where can we be a supportive partner, right? Are we at square one where, we need to kind of do some one-on-one training on F&V and physician comp and thinking about, the application of the results we might provide from a fair market value standpoint in terms of comp design, or do they have their comp models set? And, then the support really becomes more around those arrangements on the fringes, right? What are the ones that they feel like might be at or above their current risk level or tolerance level? And can we help document a fact pattern that makes that make sense? But you never know until you ask, right? And like I said, 15 years ago, this situation wasn't like this, right? Like we would go into clients and pitches, and it was a little bit more of a one size fits all. Maybe it was because everyone was working off of kind of a very similar This was all very new and fresh, right? And no one necessarily felt like they were experts in it. Now we've got a very sophisticated industry, which is exciting. The fact that there's engagement, right, in this industry in physician compensation is really exciting, right? Directionally, this is where we would expect it to go, and I'm happy that it's moving at the speed that it has.
Yeah, it's great. I think so many people have gotten involved, and over the years have come together to provide all this education, both internally and externally. When you're, just a slight pivot here, when you're going to look it down and you guys shake the magic 8-ball, what specialty do you think is going to continue to have or will be a heartburn for most clients at the end of 2026, going into 27? What do you think is going to be the most disruptive?
Most disruptive. The specialists have continued to be like I think we see a lot of outlier specialists. Like I'm talking, kind of the top tier GI, urologist, subspecialties, neuro subspecialties have continued to be ones where the data is attempting to catch up to the level of training, right, that is needed in the marketplace, right? I think a lot of the conversations we have are around what's not in the market surveys, what specialties are not in the typical market surveys, and how do you figure out what's a reasonable level of pay for those types of providers. Really those subspecialties are where I see a lot of, it's where a lot of our conversation is. But I would see that to be, as we keep going, continued specialties where folks are going to have questions and, have to noodle through tough decisions.
Totally agree. I think these subspecialties have evolved as clinical processes and the care that's being provided. It's not reflective in survey data.
Yeah.
How do you understand what one specialist is doing to another, and what's the kind of the economics underneath that? So that's really good insights. I've got one last question for you. You're a pioneer, you're leading physician compensation for fair market value. What did 10-year-old Ben want to do?
10-year-old Ben was, what was his dream? Was it physician compensation valuation? No, it was not, sadly. I think I probably would have loved to have been like professional golfer. Sounds pretty great. That still sounds pretty great if I could wave a magic wand. I've always had kind of like a interest in history. I've loved history. And so not that like being a professor sounds great, or maybe that would have sounded great, but I think maybe that career path would have been, something that 10-year-old Ben would have drifted towards.
I see it, Professor Ben. I love it. Thank you for the time today. I appreciate it.
Of course. Yeah. Thanks, Eric.